the non-neuromuscular cavus foot. This video has been produced by a book source. We would like to thank the chapter authors. Margaret Chilvers, MD, Michigan International Foot and Ankle Center, Pontiac, and Arthur Manoli II, MD, Director, Michigan International Foot and Ankle Center, Pontiac. Citation: Di Giovanni, Christopher W. and Justin K. Greisberg. Foot and Ankle. Core Knowledge in Orthopedics. 2007. There are a wide variety of foot shapes. The high-arched foot may be referred to as a cavus or cavivarous foot. The cavus foot is traditionally thought of as a manifestation of a neuromuscular condition, but it is commonly found in a less severe form in the normal population. There is a normal, bell-shaped distribution of arch height with varying degrees of flat as well as high-arched foot types. The subtle cavus foot has a higher arch than normal, but is not associated with any neuromuscular condition. The subtle cavus foot is associated with various problems, though, including ankle instability, varus ankle arthrosis, peroneal tendon disorders, lateral foot overload with stress fractures, metatarsalgia and claw-toe deformity, ankle impingement syndromes, plantar fasciitis, lateral knee strain, iliotibial band syndrome, and medial knee arthrosis. Pathomechanics. During the stance phase of gait, the normal foot position is of hindfoot eversion. This unlocks the transverse tarsal joints and allows the foot to absorb shock. This occurs through the subtalar, talonavicular, and calcaneocuboid joints. If the foot position does not reach this everted position, the cavus hindfoot remains inverted. The shock absorption is decreased. There are two main types of cavus foot. The first type is the forefoot-driven cavus foot. The cause of the cavus is plantar flexion of the first ray. When the first ray is plantar flexed, as the foot reaches midstance, the first metatarsal head hits the ground and stops the progression of the hindfoot into eversion. This keeps the entire foot in varus and eliminates the shock absorption capability of the hindfoot. Figure: rigid cavus foot with severe plantar flexed forefoot and claw toes. Another way to think of this is with the tripod model of the foot, as described in Chapter 1. A plantar flexed first ray drives the hindfoot into varus. The forefoot-driven cavus foot in the non-neuromuscular population is most likely inherited. It is usually associated with peroneus longus hyperactivity. The overactive long peroneal plantar flexes the first metatarsal, and a tight gastrocnemius complex. The second type of cavus is the hindfoot-driven cavus. The abnormality is a primary varus alignment of the hindfoot. Causes of a hindfoot cavus include congenital, untreated or late sequelae of clubfoot, calcaneus fracture Malunian, tarsal coalition, and deep posterior compartment scarring as a late consequence of compartment syndrome. Whether the primary cause of the cavus is the forefoot or the hindfoot, with time the opposite structure will become a secondary contributor to cavus. For example, if the hindfoot is the primary cause of the cavus, the first metatarsal will plantar flex to meet the ground. At first, the secondary forefoot plantar flexion will be supple, but it will eventually become a stiff, secondary deformity. Manoli and Graham 2005. Associated conditions. With any abnormal posture or alignment, there will eventually be sequelae that develop from the abnormality. With cavus foot alignment, whether forefoot or hindfoot driven, there are many associated conditions. See table. A common presenting complaint of a person with cavus is frequent ankle sprains. With hindfoot inversion, the smallest grade can tilt the hindfoot past the point of no return, causing a lateral ligament sprain. This may be seen with or without ligamentous laxity. The instability may occur within the ankle or less commonly at the subtalar joint. Recurrent sprains may lead to anterolateral ankle impingement. Peroneal tendons are constantly on stretch with the cavus foot. In addition, they are working to evert the stiff cavus foot and are frequently the site of complaints. The end result can be partial or complete tears of the peroneus brevis. The peroneus longus may be hyperactive and contribute to the cavus by plantar flexing the first ray. Brands and Smith 2000. Lateral foot overload is common with cavus alignment. The majority of the walking stance phase is spent on the lateral aspect of the foot and can lead to fourth or fifth metatarsal stress fractures. The cavus foot is a poor shock absorber due to the inability to evert the hindfoot to neutral. This may lead to stress fractures in the tibial shaft, medial plafond, or even tibial plateau. A cavus foot is commonly seen in runners who develop iliotibial band symptoms. Metatarsalgia under the first ray and sesamoid complaints may develop with a plantar flexed first metatarsal. The gastrocnemius is often contracted. This contracture will increase plantar fascia strain and can cause plantar fasciitis. Forefoot equinus from the plantar flexion of the first ray makes the gastrocnemius contracture even worse and plantar fascial strains higher. Evaluation of the patient with a cavus foot. As in all other orthopedic problems, the first step is careful history. Patients with subtle cavus foot alignment will complain of frequent ankle sprains, ankle pain, lateral foot and ankle pain, arch pain, forefoot pain, or even knee pain. Many times, they have seen other physicians for the same complaints. The most important aspect of physical examination is the standing evaluation. With the patient facing forward, line his or her feet parallel and at least 6 inches apart. In a person with cavus alignment, the medial aspect of the heel will be visible when facing forward. There may also be a bulge or wrinkle under the first metatarsal head, figure. In contrast, the normal foot or flat foot will show no medial heel when viewed from the front. This visible medial heel pad has been called the peekaboo heel sign, Beals and Manoli 1996. Figure A. Unilateral cavus foot on left, patient's right foot. Note the appearance of the medial heel on the left, while on the opposite side the medial heel is not visible. With the patient still standing, view the patient from behind. Normal hindfoot alignment is about 5 degrees of valgus. In the cavus foot alignment, the calcaneus will be in varus as compared with the midline of the calf. In contrast, the flat foot will reveal toes lateral to the foot and the classic too many toes sign, figure B. Right varus heel alignment on the same patient, viewed from behind. Note the normal heel alignment of the left foot. Once identifying the cavus foot alignment, the most important tool is the 1-inch Coleman block, Coleman and Chestnut 1977. This will differentiate the forefoot-driven cavus from the hindfoot-driven cavus. While observing the patient from behind, place the block under the heel and lateral forefoot. Allow the first 2 toes to fall off the medial edge of the block. If the hindfoot corrects to a normal valgus alignment, the cavus is forefoot-driven and the hindfoot is flexible, figure. Correction of heel alignment on Coleman block testing on the same patient. Note the same alignment of both feet while right foot is on the block, implying forefoot-driven cavus. If there is little or no correction with the block, the hindfoot is stiff in varus, figure. Same patient on a Coleman block with no change in heel position, indicating hindfoot-driven cavus. If there is little or no correction with the block, the hindfoot is stiff in varus, figure. Same patient on a Coleman block with no change in heel position, indicating hindfoot-driven cavus. Seated examination includes assessment of motion, specifically subtalar motion. A rigid or stiff subtalar joint that is not correctable on the Coleman block may be indicative of a tarsal coalition or arthrosis within the hindfoot. A supple subtalar joint will point to the forefoot as the cause of the cavus. A gastrocnemius contracture should be detected. This is assessed by keeping the hindfoot in a neutral position and dorsiflexing the ankle with the knee extended. An associated gastrocnemius contracture will potentiate the forefoot-driven cavus foot by increasing the relative strength of the peroneus longus as compared with the anterior tibialis, Manoli and Graham 2005, figure. Peroneus longus contribution to cavus foot alignment is potentiated by equinus ankle position. With the foot in equinus, the relative strength of the peroneus longus is greater than the tibialis anterior, leading to first ray plantar flexion. The remainder of the examination is performed in the same manner as for any other orthopedic examination, and feet should be taken together on the same plate. The lateral radiograph should include the lower one-third of the leg and the foot on one plate. Is directed to the presenting complaints. Ankle instability is evaluated by testing for ligamentous stability. Ankle impingement signs are directed in the accessory band of the anterior tibiofibular ligament and the anterior ankle capsule. A bone spur may occur at the anterior talofibular ligament. A stress fracture may occur within the fourth or fifth metatarsal. Peroneal tendinopathy may occur, and many times it occurs distally, near the peroneal tubercle. Imaging. Radiographic examination should include weight-bearing radiographs of feet and ankles. The antero-posterior ankles and feet should be taken together on the same plate. The lateral radiograph should include the lower one-third of the leg and the foot on one plate. Standing lateral foot-ankle radiograph of a cavus foot. Note the relative height of the medial cuneiform compared with the fifth metatarsal, and the flexion of the long axis of the first metatarsal compared with the long axis of the talus, Meary angle. Also on the lateral radiograph of the foot-ankle, the Meary lateral talometatarsal angle is measured along the long axis of the talus and first metatarsal. A normal angle is near zero, while a plantar flexed angle of 20 or more is indicative of a severe neuromuscular cavus foot. Paulos et al. 1980. For the subtle cavus foot, the angle will be 5 to 10. Standing lateral foot-ankle radiograph of a normal foot. Note that the level of the medial cuneiform is closer to the level of the fifth metatarsal. The long axis of the talus is parallel with the long axis of the first metatarsal. Continued. The last measurement on the lateral radiograph is the calcaneal pitch. A high calcaneal pitch is an angle greater than 30 and is associated with a hindfoot cavus. Normally on antero-posterior radiographs, the talus and calcaneus are divergent, with a talocalcaneal angle of 20 to 40. If the angle is less and the talocalcaneal angle is more parallel, the foot is in cavus. Also, the talar head will be completely covered by the navicular in the cavus foot, but will be relatively uncovered in the flat foot. The width of the midfoot is greater in planus feet and progressively gets narrower as the foot is in more cavus. Figure. Standing antero-posterior radiograph of a cavus foot. Note the parallelism of the talus and calcaneus, and the narrow midfoot. B. Standing antero-posterior radiograph of a normal foot. Note the divergence of the talus and calcaneus. Compare width of midfoot to the cavus midfoot. C. Standing antero-posterior radiograph of a flatfoot. As compared with the normal left foot, there is a greater width of midfoot and uncovering of the right talar head. On the antero-posterior ankle radiograph, with more severe or long-standing cavus, the entire talus may be tipped into varus within the mortise. Figure. Standing antero-posterior ankle radiograph. Note the tipping of the talus under the plafond in the long-standing cavus patient. Further tests may be necessary, depending on the associated pathology. For suspicion of stress fractures on the lateral foot, a bone scan is helpful. Figure. If the foot is rigid with no correction of the foot on the Coleman block test, a computed tomography scan should be obtained in the semiconal plane perpendicular to the posterior facet of the calcaneus, and axial cuts in the plane of the foot, to determine the presence of a tarsal coalition. Bone scan indicating stress fracture of right fourth metatarsal base in a patient with subtle cavus foot alignment. Magnetic resonance imaging may be utilized to determine pathology within the peroneal tendons. Treatment management of the cavus foot should begin non-operatively. A forefoot-driven cavus will have a supple hindfoot, and so a cavus foot orthosis can be utilized. The principles of a cavus foot orthosis are a laterally based forefoot wedge with a recessed area for the first metatarsal head. This recess allows the first metatarsal to plantar flex further, and allows the hindfoot to evert to a neutral, shock-absorbing position. Figure. Cavus foot orthotic. Note the hollowed-out recess under the first metatarsal head and the laterally based forefoot wedge and lowered medial arch. Because a tight gastrocnemius complex will potentiate the forefoot-driven cavus, a gastrocnemius stretching program is initiated. Failure of the stretching program after 2 months is an indication for gastrocnemius recession, which generally improves range of motion and complaints associated with the cavus deformity. Surgery is indicated for failure of non-operative treatment. Treatment is first directed to the immediate problem, such as a stress fracture, incompetent ankle ligaments, or peroneal tendon tear. Then, the foot is realigned to minimize the chance of recurrence. Realignment surgery varies, depending on where the deformity resides. With a forefoot-driven cavus, plantar flexed first metatarsal, a dorsiflexing osteotomy of the first metatarsal is made, figure. Alternately, a dorsiflexing fusion of the first metatarsocuniform joint can be easily performed. A intraoperative first metatarsal dorsiflexion osteotomy is a closing wedge, dorsally based osteotomy. Postoperative B, antero-posterior, and C, lateral radiograph showing position and internal fixation for the first metatarsal osteotomy. The forefoot-driven cavus foot will usually have an overactive long peroneal. The peroneus longus is then tenodized to the peroneus brevis. This transfer takes away the deforming force and strengthens the hindfoot evator, brevis. If, after the first metatarsal dorsiflexion osteotomy, there is still plantar flexion of the other rays, multiple dorsiflexion osteotomies may be needed. This is not common in the neurologically normal cavus foot. With time, a forefoot-driven cavus foot can develop secondary to hindfoot stiffness in varus. In these cases, a lateral sliding calcaneal tuberosity osteotomy brings the heel out of varus and normalizes forces in the foot and ankle, figure. In a very stiff cavavarus foot, a medial partial plantar fasciectomy may be required to allow the posterior tuber to slide laterally. A more extensive medial release of tight structures may be necessary for realignment. The medial talonavicular joint capsule and even some of the spring ligament may need to be sectioned. A intraoperative lateralizing calcaneal osteotomy. Postoperative, B, axial, and C, lateral radiograph showing the lateralization of the calcaneus and internal fixation using two 6.5 mm screws. The gastrocnemius contracture should also be addressed with a gastrocnemius recession if the contracture is isolated to the gastrocnemius, or an Achilles tendon lengthening if the entire posterior complex is contracted. In a severe cavus foot deformity associated with neuromuscular disease, a triple hindfoot arthrodesis is needed both to achieve the realignment and to maintain the correction. Extensive hindfoot fusion is usually not needed in the neurologically normal cavus foot. Claw-toe deformity. These subtle cavus feet can develop severe claw toes, which contribute to metatarsalgia and can rub on shoes. When a shoe with a tall toe box is no longer able to relieve symptoms, surgery is indicated. Muscle balance is achieved by transferring the long toe flexor to the extensor over the proximal phalanx. This encourages extension at the interphalangeal joints and flexion at the metatarsophalangeal joint. Metatarsophalangeal or interphalangeal capsulotomies are performed as needed. Fixed proximal interphalangeal joint contractures will need formal joint arthroplasty or fusion, with temporary pin fixation. Thanks for watching. Kamal Gokas MD, Baskent University, Alanya Research and Practice Center. Orthopedics Trauma in YouTube. Subscribe.